Welcome to the Jack Westin MCAT podcast with your host, Phil Hawkins.
And Azaii Calderon Muñiz.
All right. Welcome back, everyone. I am super excited. We kind of did that weird interlude in the podcast episodes. We had so many students asking about Azai's story and my story. And we're very happy to share because I think like understanding other people's journey kind of helps you understand your own journey at times. But I'm excited to get back into science. So we are continuing our deep dive into some of the biology topics that shows up on the MCAT. And today we're going to talk about a very important topic that, to be honest, there's a good chance that this topic might be your entire career, like as a physician. And so we're going to talk about diabetes. Diabetes is one of the things that like amazed me how often it came up when I worked in a clinic. And like there was one day where I think it was like 10 or 11 patients in a row all were diabetic. And like, it wasn't a diabetes clinic. Like this was just like, I'm just dealing with patients. And so there's a lot of interesting things about diabetes. It is a growing part of the demographics of the United States. And so I don't think it's possible to become a physician and not have to be able to understand how diabetes kind of works and what's kind of going on with it. I think that that's something that even people who have diabetes, some people don't really understand kind of all the ramifications and stuff with it and how it all works. So I am super excited that we are going to dive into this. This is something that once again is testable in the MCAT, but also really big in just like medicine. And as a physician, this is going to be something you're dealing with. That being said, a big part of diabetes relates to metabolism. And we are not going to do a deep dive into like the pentose phosphate pathway and glycolysis and gluconeogenesis and glycogenolysis and glycogenesis and like all of those things. Like you need to make sure that you understand those kind of outside of this context, either like review it, before the episode, which you might not have done, or after the episode, but like make sure that you have an idea of what's going on in these processes. And we will touch on them, but just something that we want to kind of throw out there to begin with. We're going to be focusing on diabetes specifically. And so we will talk about how that relates to those processes, but we're not going to actually do a deep dive into those processes overall.
Yeah, I love that you mentioned how important this is going to be for, future physicians, right? All of the folks that are listening to us, because you really can't go a single day in a medicine clinic, depending on what, part of the country or where, the region that you might be in, without seeing someone who has diabetes and having to follow up on that. You're getting messages from patients, regarding their fasting blood sugars, right? When they're taking their blood sugar at home, their medications, side effects, things like that. So the more common it becomes, the more important it becomes for future physicians, for you guys to have a really good, clear understanding of what diabetes is and how it can cause problems. Why? Because, and I think, Phil, you've probably mentioned this in prior episodes, perhaps even last week, how important it is to just be able to explain to patients, right, what diabetes is, how it affects them. And so you guys having a clear understanding makes it possible for you guys to do even better as future physicians. So we're specifically going to be talking about diabetes mellitus. And so that is a little different than diabetes insipidus. You don't have to know that for this. But there are two main types of diabetes, as we'll just call it, from here on out. And so that's type 1 and type 2. So imagine yourself on a long road, right? And you are in your car and there's a house and you want to go into the house, right? Let's say you've gotten permission ahead of time. So you get out of your car and you see the key on the ground, right? And you want to get into the house, but there's no lock. On the next house, right, there is no key in sight. The lock is there, but you don't have the key to get in. These two can actually be used, these two kind of scenarios can be used to understand diabetes. So type 1 diabetes would be you're lacking insulin. You are lacking the key to bring the glucose, right? You are the glucose into the house, into the cell. In the first scenario, and I probably should have flipped those two as I'm saying this out loud. In the first scenario where you saw the key on the ground, right, and you, the glucose, want to get into the house, but there is no lock, is a case of there's insulin resistance at the level of the cell. So in one, there's insulin not there, right? So the cell isn't getting that signal, hey, let the glucose in. And then in type 2, the insulin is there, but the cell isn't hearing the signal very well. And so it's not hearing the signal, hey, let the glucose in. So those are just kind of two ways to think about this, but they have very important results, right? So in type 1, you actually have this absolute insulin deficiency, and it's at the level of the beta cells in the pancreas. So they're just not producing it. In that case, that person needs insulin, right? You can't get away with not giving them insulin because they just don't have any. In the case of someone with type 2 diabetes, they have this insulin resistance, and eventually over time, their beta cells will, start being destroyed, and they'll also produce less insulin. But at the beginning, you don't need to give them insulin. You can use other medications, other, dietary changes, things like that, lifestyle modifications to help improve their blood sugar. And so they have, aside from mechanistically being very different, that mechanism also has very different ways that allow you to treat and care for these folks.
Yeah. And I think it's really important to understand a lot of people at an initial glance, obviously know the connection between insulin and diabetes. But they think that insulin is doing something with glucose. But insulin actually doesn't do anything to glucose. Insulin is, I always like to think about it as a town crier, which I know makes no sense in today's world. But basically, insulin is running around in your body, and all it's doing is just shouting, we got plenty of glucose, right? We got plenty of sugar. And it's just telling all the tissues of your body, like your muscles, your liver, your kidneys, your brain, kind of everything. And it's just telling you hey, we got plenty of glucose. And all of those tissues are going to deal with that a little bit differently, right? If a tissue like the liver, it deals with glucose in a different way than the kidneys or your skeletal muscles do. And so insulin is really just a signal shouting to all of your body, we got plenty of sugar lying around. I do want to kind of take a second to talk a little bit more about type 1 and type 2. Type 1 diabetes is something that used to be called child diabetes, or that's kind of gone away as we start to get more and more children with type 2 diabetes. The reason for that is type 2 diabetes really comes from if you have your insulin running around shouting we got plenty of glucose. After a while, your body kind of quits paying attention to that, right? And just kind of ignores it. And so that becomes a problem in type 2. And it's generally type 2 is caused because you have high blood sugar all the time or very often. And so your body just tends to ignore it and start to resist those signals. Just kind of your body will develop tolerance for all sorts of different things, in drugs and medications and stuff like that. And so there's kind of a difference in the causes of that. And so there are things you can do with type 2 to kind of pull that back. Type 1 is, as you mentioned, a little bit different. That's more of an autoimmune thing where your body just attacks the beta islet cells of the pancreas. And so you just don't have insulin. And so those are the people who need, you have to give them insulin to solve the issues. But type 2, there's, as you mentioned, so many other ways to try to mess with the resistance and try to bring glucose down. And so your body is screaming about insulin a little bit less often. And so your body kind of starts to pay a little bit more attention when it does. Insulin does do the signaling. And so I think that that's a really important thing overall. But big picture, when you have tons of glucose, then your body's going to deal with that differently. All of a sudden, your muscles will start to burn glucose as a fuel source. But if you don't have any glucose around, or if your insulin isn't screaming about, hey, there's plenty of glucose around, then your muscles won't do that, because glucose is kind of this weird thing that and like maybe it's more of a neuro thing that's weird here, but like your neurons are kind of picky when it comes to fuel sources. They tend to work off of glucose way more efficiently and like not really work off of other fuel sources. Like your muscles and your liver and your kidneys, they can do other things. And so when you don't have glucose around, basically the rest of your body is trying to conserve the glucose for your neurons. Because if your neurons don't have glucose, they're going to die and they don't come back. And like your body like kind of deals with this in a way so that if you don't have hardly any glucose around, or if you just have a little bit, then like your body is not going to be using that glucose. If you have lots of glucose around, like plenty, then all of a sudden it'll start to use that as a fuel source because it is a pretty efficient fuel source. And so when things go wrong, where you have like either insulin is gone or your body is not listening to that signal, like for insulin, then your body thinks that you're low blood sugar, even if you're not. So even if your blood sugar is really high, but there's no insulin or the insulin receptors aren't working and like you're resisting insulin, in that case, your body is going to act like you are low in sugar. They're going to act like you're starving. And that is a really important thing to kind of understand how this all works together.
Yeah, I think this is something that I've seen trip up students in the past. They're like, oh, well, but the level of glucose in the blood is high. And so when answering questions, they'll want to work off of, oh, the blood glucose is high. But you have to really think about in terms of what pathways are being activated, what pathways are being up or down regulated. You really need to think about what the cell is seeing, right? And if the insulin is not screaming, hey, we have glucose, the cell thinks that it's fasting, right? And so it's going to be those fasted metabolic pathways that are going to be upregulated, right? And those fed pathways are going to be downregulated.
Yeah. I like to think about like the body thinks you're starving, even though your sugar is really high and you have plenty of fuel, your body doesn't know it and it thinks you're starving, which is like the opposite of the actual truth, but it doesn't know any better.
Exactly. And that's why this is a pathological state, right? That's why this is something in the system is broken. So it can kind of be helpful. And like we said, we're not going to go into specific details of the metabolic pathways. You guys got to go review that. But we are going to name some of them, right? So glycolysis. So glycolysis is the breakdown of blood glucose. Well, if your cell doesn't think, and the cells in your body don't think that there's glucose around, they're going to decrease the rate of glycolysis, right? They're also going to think that, hey, we don't have enough glucose in the bloodstream, so we need to make more. So gluconeogenesis is going to be increased, right? These are some of the pathways that you have to think, okay, what would, in the fed or happy, or I, have plenty of glucose, what would be normally on? And that turns off is essentially what's happening, right? So I
feel like that's so backwards, right? With that, like your glucose is really high, but your body is still building glucose and dumping it into the blood, which just makes things worse.
Exactly. And that's why it's so important, and kind of just off on a momentary tangent, but that's why it's so important to get diabetes under control quickly and swiftly, because our best measure of it, right, is going to be in terms of how well controlled it is over the course of a couple of weeks or months, is measured once every 3 months. And that's your hemoglobin A1C. And that's essentially, and I think we've talked about this before, that's essentially measuring how much sugar there is on your red blood cells. And since they take approximately, right, a few months to turn over, then you need a few months between these readings to have something really meaningful. And so it might be a while, it might take a while to get blood sugar under control. And you may not see that officially in the numbers for a couple of months, depending on how you're measuring it. So making those changes at the beginning is really important for patients. But thinking back to the specific pathways. So we also have glycogenesis. So the formation of glycogen to store glucose for future use, right? Well, if you don't think there's glucose, why would you try and store it? You wouldn't. Right. So even though there's all this fantastic glucose, maybe not fantastic, but even though there's all this glucose in the bloodstream, your body still doesn't know what to do with it. It hasn't heard the signal, so it's not going to store it. Right. It's just going to stay in the blood vessels, which is a problem in and of itself. And so then the breakdown of glycogen, right, the opposite process is going to be increased. So you are making glucose from scratch, right? Think amino acid breakdown and using that in gluconeogenesis, but you're also breaking down glycogen stores. And so you're releasing even more glucose into the bloodstream. So now you have cells that aren't seeing the glucose. They're not taking it in. There's signals in the body that are telling you to make glucose, right? From other substrates, from other things that the body needs. The body still needs amino acids, right? And it's also getting the signal, hey, whatever you have stored, let it go. Let it into the bloodstream. We need it. So like you were saying, Phil, we have these, different cell types that are going to respond differently. So the liver, right, is thinking long-term. And so it's thinking, okay, am I storing glucose or am I producing it? So it's kind of going to be in charge of that glycogen, breakdown or formation and that gluconeogenesis. Your muscles though, right, they're going to be used for gluconeogenesis. So they're also going to start getting broken down, right? They're not going to take in the glucose as much. They're not going to synthesize any glycogen. The adipose tissue is also going to respond. And so you're going to have less glucose uptake there. You're also going to have less, more lipolysis, so breakdown of fat. And I think what a lot of times we don't realize is that this diabetes and this really high glucose state can also cause a lot of fat damage, essentially, just because you're releasing so much into the body. And so it's damaging from all sorts of ways, right? At the level of multiple different cell types. And so for the purposes of the MCAT, you should know the different pathways that are involved, right? So, glycolysis, gluconeogenesis, et cetera, some of the ones we've mentioned. You should know what's happening in what cell type. That's important. And then just know the physical manifestations. So this next thought is one that it took me a while to understand. Why would someone who has high blood sugar possibly lose weight? Why would that even make sense? Under what circumstances, right? That doesn't make sense. That's not what I see. But that's a way that I've seen them trick students before. We've had these conversations with students before. If you have to break down muscle and fat in order to produce more glucose that the body doesn't actually need, but it thinks it needs, you're going to have muscle breakdown, right? You're going to have breakdown, and it's a pathologic breakdown. So it's not healthy, but they could very well ask you a question. And one of the answers might be related to muscle wasting. So being very cautious and ask yourself, do these cells think that we are starving or fasting, or do they see the glucose? Yes or no? And use that to guide you.
Yeah, that's something that trips up a lot of students because obviously diabetes is also related to being overweight. And so they think that, diabetes makes you gain weight. And there is some stuff with that, like your body thinks that you're thinks that you're starving. So actually you tend to be hungry more. In this case, it actually increases hunger. But overall, your body doesn't know that glucose is there. It thinks you're starving. So it's doing all the things that it does when you're starving. It's breaking down fat. It's breaking down muscle. It's breaking down your body kind of overall. And that can have some big effects, obviously, kind of down the line as you start to damage muscles and damage different tissues because your body thinks you're starving, even though you're not, right? And it's a little bit counterintuitive, right? To be your blood sugar is so high. Why would you lose weight, right? Why would you be burning fat? If you've got tons of glucose, but Azaii, like you mentioned, it's pathological, right? There's something wrong here, something broken in this. Now, I think that a lot of this, this kind of sounds bad, right? But some of you guys might be thinking wait, if diabetes just means you lose weight and issues like that, kind of what's the problem? And there are some patients and people I've known with diabetes that's my glucose levels are pretty good most of the time, but every once in a while jump up to 300 and I'm that's a problem, right? And I think one of the most important things about this is that glucose damages blood vessels, right? And this is actually what causes most of the problems, the critical problems that you see in patients with diabetes. And like high glucose levels, they do all sorts of things. They kind of like mess with nitric oxide, which is a vasodilator. So without that, you kind of vasoconstrict. It also messes with the elastic nature of your blood vessels, so they become a little bit less stretchy. And so overall, like people who have diabetes that is uncontrolled and they just have really high glucose, their blood vessels tend to vasoconstrict and get damaged and broken. And this is why, like one of the main problems that occurs in patients with diabetes is they like lose a leg, right? Or what's happening there is they're damaging the blood vessels in their periphery. And so like it's a long ways from your heart to your toes, right? And so if you damage the blood vessels all along that path, like eventually, like it's hard to get blood to your feet. And so what happens there is you can get less glucose. And so by damaging the blood vessels, all of a sudden you're getting less blood there, and which means you're getting less blood to your neurons in your leg. And so all of a sudden you have neuron damage. And so like you can't feel like if you get a cut, like you lose some sensation. And so patients with diabetes will get like a cut in their foot and they won't notice, and they'll walk around, they'll have like a rock in their shoe or something, and they'll walk around on the rock because they don't realize that they have damage. And that just makes it worse. And then because the blood vessels are damaged, your body can't get your immune cells to that area. And so if that gets infected, all of a sudden your immune system can't get to that area because the blood vessels are so damaged. And so you like develop an infection that gets really bad and you can't fight it. And it just like takes over your leg and you have to amputate. And that's a pretty common thing with diabetes. The thing is, it's not just like legs, right? It's just that's the farthest from the heart. And so that's one of the places where like, the aggregate damage that occurs, like that's one of the first places you see that. You also see this in like hands as well, if it's really uncontrolled. But it's not just about like losing limbs and things like that. Diabetes will also damage like the blood vessels in your retina. And so there's diabetic retinopathies. And so having diabetes that's uncontrolled can make you go blind. And just having like a spike of glucose, even if you're, under control most of the time, but you have these big spikes, like during those spikes, damage might be occurring. And so even if in those patients, I'm like, listen, like you can't do those spikes where you're like, oh, I'm taking care of it most of the time, but then, I'll party and have like eat an entire cake. And I'm like, well, that's a problem because you're damaging your blood vessels, and like that might make you go blind over time. And like, that's obviously some severe issues. It can also damage your kidneys. And so all of a sudden, like damaging your kidneys, specifically like your glomerulus, which keeps, I don't want to dive deep into like how the kidney works, but the glomerulus stops proteins from getting into your urine. And so if you damage that, all of a sudden you're going to be peeing out proteins, which has a whole other slew of problems that causes like edema and a lot of other things kind of over there because of like kidney damage. And so there's all sorts of like things going through there. And I think helping patients understand that, like, listen, like this isn't just about like, oh, my blood sugar's high, I feel like crap, right? Like, no, this is like, this will cause kidney failure, right? This will cause you to go blind. This will cause you to like lose your legs and your fingers and your hands. And like, you have to control this. And so that's an important thing to keep in mind. I will also say something else kind of interesting about the kidneys. And this is kind of an interesting thing. So your blood like goes eventually into your urine, and then your body like does all these things, like pulls stuff out and puts stuff in and kind of like changes the constituents. So blood and urine aren't the same things, but everything that's in your blood could end up into your urine if you don't like filter it or secrete or reabsorb whatever. And so normally our body reabsorbs the glucose in our kidneys that's from our blood. And it does that actually through S-GLUT, which is a special glucose transporter. There's like GLUT 1, 2, 3, 4, and then there's S-GLUT, which is special. It's the special glucose transporter, I really like that. And so I think it's S-GLUT2. It's like the second, which I feel like makes it less special. It's like the special glucose transporter number 2. And I'm like, okay, whatever. And I don't think you guys need to know specifically the name of the glucose transporter. But know that there are like different glucose transporters in different parts of your body. And so your body is reabsorbing this glucose like from your blood so that you don't pee out glucose, because under normal conditions, like you kind of want to keep your glucose. If you're a normal, like controlled, like glucose, non-diabetic, like your glucose is valuable. It's a fuel source. But if you have really high blood sugar, it overwhelms your kidney's ability to reabsorb it. And so normally it is reabsorbing this glucose and your body is still trying to reabsorb it, but there's so much glucose in there because your glucose is so high that it can't reabsorb it all. And so something that you see in patients with uncontrolled diabetes is not only do they have protein in their urine, but they also have glucose in their urine. And this is one of the like weird, gross things with medicine, but like turning back the hands of time, like the way that you used to test for glucose is or test for diabetes is you'd have a patient pee in a cup and then you take a drink of it. And then you'd be like, ooh, that tastes sweet. You have diabetes because there's glucose in your urine. Luckily, that's not what physicians have to do today, but back in the day, that's how they would diagnose diabetes. Turns out there are other ways. You no longer have to drink urine as a physician. But yeah, it's kind of an interesting thing. And like that also comes with other issues, like the extra glucose in the urine means that bacteria, like that's a fuel source for bacteria as well. So you tend to get bacterial infections and like bladder infections and things more common if you have diabetes. And so like there's a whole slew of things, and like understanding how all these things kind of fit together is really important, because you know, a lot of times patients just think like, oh, if my diabetes is uncontrolled, I just feel like crap for a day or two and then I get it back under control. I'm like, no, like there's a lot of stuff kind of connecting here.
Yeah. I just want to say this once. If you try and make me drink someone's urine as a physician, you are getting my letter of resignation same day. But no, this is really important. Like in all actuality, you know, maybe most of the patients that I see haven't gotten to the degree of having lost a limb, but many of them have started losing sensation. And the crazy thing is that it's not just, oh, like you just don't feel like if you step on something. No, like that can alter your ability to, like that can alter your lifestyle, right? Like if you were someone that really enjoyed hiking, right? As you're getting older and now you're starting to lose sensation, that becomes dangerous. You're going to be more worried when you're out hiking. You have to pay a lot more attention.
Right. I recommend, you can't tell if the ground's uneven.
Yeah. And like, so that's also something as well.
Balance issues. Right.
Yeah. So like I've asked patients, like, can you feel like the ground fully on your feet? No. And that's tough, right? That's a tough position to be in. Also just kind of keeping in mind, like, when we talk with our patients, we have them do daily foot checks. Imagine having to now spend the rest of your life every day checking your foot to make sure that there's not a cut and to make sure that you don't have some roaring infection and now have to go to the doctor. That's a lot of mental stress as well, mental and emotional stress. So it's the physical, it's the mental, it's the emotional. There's a lot going on here for patients with diabetes, which is why early on, you know, we try and figure out, okay, how can we treat this? How far along is this? And where can we intervene? Where can we do something about this, right? And so we hinted at that a little bit earlier. It depends on the type of diabetes you have, right? So if you have type 2, you need insulin. And again, this is something that I think people don't always realize. Imagine having to inject yourself with insulin before every meal or after, you know, if you have a high, like that's a lot. It's a lot. If you have type 2 diabetes, let's say that it's early on, things like what you were saying, Phil, you know, food, decreasing the amount of time that your body spends screaming, hey, we have glucose, you know, is helpful. We have patients, even when they're on medications, try and adjust their diet so that they rely less on those medications so that they're less likely to need insulin. One of the medications, though, that we put basically everyone who has type 2 diabetes on is metformin. And so metformin only works for type 2 diabetes because what does it do? It decreases insulin resistance. So think back to our little driving in the car, getting out and trying to get into the house, right? In type 1, there we go. There are no keys, but the lock is there. So you don't have to do anything with the lock, right? The insulin resistance, that's not the issue. But in type 2, you keep driving, you go down to the next house, right? You have the key, you have the insulin, but you just don't have a lock. So it's like metformin is kind of like adding a lock so you can get in. And so that's something that, a lot of patients will, if you see that, they have type 2 diabetes and not type 1. That's future pearl. But we also have other medications that act at different points in the pathway. We didn't talk about, the full hormonal regulation in diabetes, and that's something that you guys can, look into. But we have medications that act at a hormonal level. We have, and just beyond the usual, like insulin and glucagon. We have medications that act at those SGLT2, transporters. That's the word I was looking for. And so we actually have inhibitors of those. So they can't reabsorb the glucose. They force someone to urinate all this extra glucose that's in their bloodstream. And that's one way that we actually help patients. Now that comes with its own side effects, right? And you actually, for folks who are on these medications, you have to frequently check their kidney function. And think about it, you are peeing out all this extra sugar, all this extra glucose. It's also acting as a diuretic, right? So now you're peeing all this extra fluid as well, and water. So you have to keep a close eye on folks who are on these medications. There are a lot of different medications that work at different pathways, but it's helpful to understand at what level they're working. And in the future, for any of you who might be having to prescribe medications for someone with diabetes, you can think about, okay, what parts of the pathway have we already targeted? What parts of the pathway haven't we targeted and have good responses, right? And note that, a lot of this depends on other factors. And we were talking about, how diabetes can contribute to losing eyesight, kidney damage of your neurons. Diabetes rarely occurs in true isolation, meaning chances are if they have diabetes, they probably also have other medical conditions, right? Some of it might be related to their arteries. And we already know that from what you were telling us, diabetes can cause problems with your blood vessels. So then that's compounded. And so it's really important to think of not just the illness, diabetes, but also the person who has it and what else they might have going on in their life when you're thinking about your future patients. Very rarely does a medical condition occur in isolation like this.
That's a really good connection, especially because type 2 diabetes tends to occur in patients who eat a lot of high sugar things kind of all the time, right? Because that raises their blood sugar all the time and the body just kind of quits paying attention to the insulin. If you're overweight, right? If you are obese, and you have diabetes, obesity already puts a huge strain on your cardiovascular system. Adding diabetes on top of that damages your cardiovascular system, even above the cardiovascular issues that you already have. I think that diabetes is something that has really exploded over the last 50, 60 years. The rates of diabetes has been a very sharp uptick. I think also, just a side note, the number one cause of death of Americans, it's not cancer, it's not COVID, it's not whatever, it is cardiovascular disease. And the increasing rates of diabetes is making that worse, right? So the most likely thing to kill any of your patients, just if you know no other information about them, is heart and vascular issues. If they're diabetic, that just really turns up the likelihood of that becoming a real problem. And so this is something, like I said, every physician needs to be aware of this. Every physician needs to deal with this. Just as a side note, as kind of a commentary on society, there's a lot of sugar in a lot of food. And high fructose corn syrup is added to pretty much everything. And then you'll get soda, soda pop. There are people out there who drink a lot of it that is not diet versions. And the diet versions they have other stuff in them, but they don't have glucose. And if you have issues with glucose, soda is, I think, one of the easiest ways to make that way worse. Just a side note. I know I've talked about this in the past, but my dad actually is a type 2 diabetic. He developed it when I was still in like middle school. But I remember my dad's a farmer. And so he would like, he's like sitting in a combine like all day, or a planter or a semi. And I remember what he would do every morning is he would go to the gas station. He'd get like a big cup of ice, and then he'd buy two liters of Coke. So he'd buy 4 liters of Coca-Cola, and he would drink that every day. And like, that's what caused him to develop diabetes. Like that caused the diabetes was just like by drinking. And like, that's a huge amount of soda. Like, of course that's going to cause diabetes. Like, you can have things with like less soda as well. But my dad's on metformin. My dad's on SGL2 inhibitors as well. And you're right, they are diuretics. And like, my dad hates that because all the extra glucose in the urine that he's peeing out makes him have to pee more often. And so he hates it because he has to pee like every 30, 45 minutes. But I'm just like, oh, Dad, if you like took a lot better control of your, blood sugars, then that's less likely you could maybe get off of those and not have to pee as often. But yeah. And so those are things that like is really important to understand, right? As a physician, as an American, like, because diabetes is so prevalent in America. I honestly think that like what we're talking about today, honestly, probably every American should understand and know about, because even if you don't have diabetes, people who have diabetes, you see people, you interact with people. And so understanding that disease a little bit better helps you kind of understand other people a little bit better and kind of like what issues they might be going through. So definitely a lot to go on with diabetes. And I'm really glad that we were able to talk about this. This is not the last time you're going to hear about it, but understanding it better. Obviously, the MCAT is going to test you on this. And I actually think as I said, understanding all of like the systems and the cells in your body and understanding like what cells are doing what things in terms of metabolism, that's something that is very likely to show up on the MCAT. And so I'm not just doing this because everyone should know this, but also this is stuff that you like is highly testable. And so I would not be surprised at all if you had a passage on metformin or a passage on SGL2 inhibitors or a passage on diabetic retinopathy. Those are all like topics that are fairly highly researched. There's lots of articles out there. It'd be very easy for the MCAT to tap into that and give you a passage on that topic on test day.
For sure. And this is just like a really important reminder: connections. Look for connections between pathways, between, normal and abnormal. That's like the MCAT loves testing relationships. And the more you can make those connections before you see them on a passage, the easier reading a passage on a topic you're less familiar with will be. So if they give you, a passage on an SGLT2 inhibitor, right, you don't have to be an expert on it to still do well, recognizing those connections. And one last really important thing, you guys are going into this field where you have to keep track of like, just also remember that the person in front of you is a person, right? And you don't know their entire backstory. And so, it's important to just keep in mind that these medical conditions are medical conditions, right? And I think a lot of different medical conditions have stigma associated with them. And we have a tendency to say like, oh, well, just don't eat XYZ, ABC, whatever. Keep in mind that people have different relationships with food culturally, right? Keep in mind, like Phil, like we were saying, it's really hard to find foods nowadays, in like at a random convenience store, grocery store that wouldn't worsen blood sugar and whatnot. So work with your patients and don't just talk at your patients. Really important thought. But we're really glad that you guys were able to join us on this little walkthrough of diabetes. Hopefully you've learned a lot, and hopefully you can have a productive conversation with someone in your life about it.